Started. Let me introduce our speaker, and we'll get into this exciting talk and this exciting topic. So, Dr. Adnan Qureshi is a professor of clinical neurology and program director, endovascular surgical neuroradiology fellowship at the University of Missouri School of Medicine. He is also the executive director of Zinat Qureshi Stroke Institutes, the ZQSI. He has written over 750 scientific publications in prestigious journals and 14 textbooks. Dr. Qureshi has served in several leadership positions in clinical trials pertaining to interventional neurological procedures and stroke. And he has also received several prestigious awards at the national and international level. Recently, his work has focused on neurological and cardiovascular complications associated with SARS-CoV-2 or COVID-19 infection. He has led an international panel to develop management guidelines for cerebral vascular diseases in SARS-CoV-2 infected patients. So it's my pleasure now to pass it along to Dr. Qureshi to begin his interesting talk that you're all waiting for. The floor is now yours, Doctor. Let me know if you have any issues presenting.
Thank you so much, Stephen. I really appreciate you putting all this effort to bring it together. And I was very excited to see the global forum that we have today. I mean, I was reading through all the people that are attending from all over the globe, so it really is very exciting. So I'm going to actually talk about the increased prevalence of dementia and other neurological diseases in SARS-CoV-2 infection survivors. And our interest in the SARS-CoV-2 infection or the coronavirus 2019 started because there were reports that patients who actually were having SARS-CoV-2 infection were at higher risk of having ischemic strokes. So essentially an infectious disease with a prothrombotic sequelae, so to say, or acute sequelae. And we did several studies on that. Our first study was actually looking at 27,000 patients who actually had SARS-CoV-2 infection. And then essentially how many people actually developed acute ischemic stroke. So we found that 1.3% actually developed acute ischemic stroke. But actually it's very interesting that if you look at a cohort of patients in whom SARS-CoV-2 infection is excluded, around 1% developed acute ischemic stroke. So I think that based on that research, I think some of the new finding that came out is that perhaps the risk of having an acute ischemic stroke in the acute phase of SARS-CoV-2 infection is not as high as people had initially anticipated, and perhaps may not be a lot different than people who are just admitted to the hospital for other infections. So as the survival after SARS-CoV-2 infection increased, the focus of care shifted from the acute phase to more of what we call the convalescent phase or the recovery phase. And a large proportion of people who had actually suffered SARS-CoV-2 infection survived the infection, fortunately, and moved into the survivor category. And if you look at the number of survivors all over the world, over 500 million people are considered survivors who have survived the SARS-CoV-2 infection. So that's a pretty large number of people who have survived the infection. And the question then becomes, are they back to normal life? Have they integrated back to their normal activities? Or there are consequences that we do not know, even after they've recovered from our classical definition of the acute phase. So I actually have a question here. And I think it would be interesting to know that what do people think? So I just showed you the global figures that are around 500 million people. So what do you think in terms of United States? So a population of around 320 million people living here. How many people would actually be survivors of a SARS-CoV-2 infection?
Okay, give me a sec. I'll play that
Sure.
for you. Open poll. Do we see the polling? Yeah, I'm getting votes in.
Okay. Well, I'm excited to see what people think.
We'll let it run for maybe another 5 seconds.
And again, these numbers are based on people in whom the infection was diagnosed. So there is an unknown group of people who had the infection, never had the
Close.
symptoms, and never was the need to be screened or diagnosed.
So the results of the polar processing now. You'll see the results in a second.
Okay.
Do we
So
see the
yeah,
results?
okay, I'm anxious. I'm excited about the.
Oh, sorry, I have to share them. My apologies. You should be able to see them now.
Well, I think most people seem to be pretty educated on this topic. Uh, so I think they're dead on the money. So let's see what the actual number is. So let me actually go to the next slide. So can we go to the next slide, Steve?
Oh, I believe you have the control.
Oh, you gave it back to me. Good, good. Okay, let me see. Okay,
There we go.
so here's actually what the number looks like. So it actually there is approximately 80 million people in United States that actually were diagnosed with the SARS-CoV-2 infection and actually survived the infection. And that actually means 1/4 of everybody living in United States actually has suffered the infection or was diagnosed with it and has survived. So that just gives you the proportion of the survivors that are actually in just United States. So obviously this is a much greater issue than the issue one would have anticipated with acute infections with the SARS-CoV-2 infection. So then, I'm sure all of you have heard, either by meeting patients or meeting survivors, even family members who have survived, that they just don't feel normal after recovering from the infection. And I have heard various terms, so where they would actually say that it's all like a brain fog, and nobody knows what that brain fog means, except it's just a delay in functioning and a inability to process cognitive information and mental functioning at a pace that they were comfortable with doing before they had the infection. And obviously, the question becomes is how prevalent is cognitive impairment after recovery from the SARS-CoV-2 infection? And I think really depends on the definition. How are you defining cognitive impairment? If you're actually defining cognitive impairment is something that actually requires detailed testing, and we're talking testing not the MOCA test, not the MMSE test, we're talking testing that requires probably an hour or 2 hours to actually get through it. 20% of the patients, and these are non-hospitalized patients, so we're talking patients who are pretty healthy during the infection, would actually have cognitive deficits. On the other hand, if you're looking for dementia, so dementia that is medically diagnosed and has received a code based on the ICD-10, around 2.6%. So there is a spectrum depending on the definition, and perhaps the spectrum is also defined by the severity of the initial illness. So when we talk about cognitive impairment, I think that there is a whole spectrum of cognitive impairment that you can see in patients who have survived the SARS-CoV-2 infection. And again, the more sensitive your test is, the more diligent you are to trying subtle cognitive deficits. Obviously, the proportion of such patients is much higher, and may even as high as 1/5 or 1 out of every 5 patients who actually has survived the infection. So here actually I put another question. So, what kind of cognitive deficit do survivors with SARS-CoV-2 infection have? Do they have mild cognitive deficits that may or may not be detected by MOCA and MIDI mental status? They always have severe cognitive deficits, or they actually have dementia that impairs multiple cognitive and functional domains.
So the poll is now open. We'll give it 5 to 10 seconds to let everyone put in their answers.
So in some ways, I think that we missed the last question option, which is you could be A, B, and C. So let's just say that we will assume if you tick D, that you mean A, B, C, and A, B, and C.
Okay, we'll be closing the poll now. I got a lot of responses.
Okay.
You
Okay.
see the results? Yeah.
Yeah, I think that everybody is correct on that one. So it seemed like there is a whole spectrum here, and I think that it just how diligent we are to capture the spectrum and what group of patients that we are screening. And I guess the one thing that we just don't have long-term data yet is when we are screening. So perhaps the proportion may differ if we are screening at 1 month versus screening at 6 months or 12 months. So one of the things we started actually looking into was the prevalence of dementia in survivors of SARS-CoV-2 infection. Because dementia actually is not the kind of cognitive dysfunction that allows you to integrate back in the society in some functional level. In fact, dementia is a pretty debilitating kind of cognitive deficit, or it's the extreme spectrum of cognitive deficits. And it has significant implications. You have what kind of care they would require once they develop dementia, what kind of resources will be required to make sure that they have the level of care. I think there's a large caregiver burden. There's obviously financial issues from a societal perspective, if not just an individual perspective, and a productivity set of issues. And obviously, the impact on public health is much larger. So if you just look at acute infection, within 1 month, that part is over. But for every survivor, which may be more than 500 million people in the world today, the burden of dementia is a lifelong burden. So this is not a burden that will go away in 1 month, not in 3 months. This is a lifelong burden that they have to live with, and their families and caregivers have to live with. So one of the challenges obviously is that, yes, we saw people who have SARS-CoV-2 infection may have a risk of dementia. But people who have infection in general also have a risk of dementia. And I think that's been known for the last 15 years. For example, if you look at a cohort of people who have bacterial pneumonia, so, not the people who have SARS-CoV-2 infection, but actually before that, people who actually had bacterial pneumonia, and they did not have any history of dementia before they had the infection. And then you have another group of people. So in this particular study, it's a 1 to 10 match. So for every one patient with bacterial pneumonia, they're matching into 10 patients without bacterial pneumonia. And then they're just following these patients all the way from somewhere between 3 to 17 years. And actually looking at the risk of dementia. And actually, if you look at this study, you can obviously see that there's almost a threefold higher chance of developing dementia among patients with bacterial pneumonia as compared to a matched group of patients who do not have bacterial pneumonia. So clearly there is a relationship between infection and any pneumonia and the risk of actually developing dementia. And actually in this Kaplan-Meier curve, you can actually see the risk actually starts very early. So patients who actually have bacterial pneumonia, they seem to be developing dementia very early after completion or recovery from their disease. So whatever is happening during the infection seems to take a toll on the brain, either in the acute phase or actually even continuing in the post-acute phase. and essentially predisposing them to having a much higher risk of having dementia. So obviously for any research, this has to be considered, because if what we are seeing in these patients is something that would have been expected with any pneumonia, so then it really has nothing to do with the SARS-CoV-2 infection or nothing unique with the SARS-CoV-2 infection. So we started to actually do a full analysis. Obviously, there were anecdotal reports coming in, and the question was, whether this is something real, and then whether it's something that can be separated from the acute encephalopathy that can happen in the acute period of the SARS-CoV-2 infection. So we actually used the Cerner real-world data. So this is actually a electronic medical record-based data, and it actually takes data from 110 contributing sites. So it's a pretty representative data, at least from the North American perspective. And this is our design. So we took 10,403 patients with SARS-CoV-2 infection, and we took another 10,403 patients without SARS-CoV infection, but all of them had pneumonia. So they actually had a medical encounter for pneumonia with a concurrent encounter either for SARS-CoV-2 infection or another infection. So these are the groups, and they are actually matched. So they are matched for age, gender, race, and ethnicity. And to make sure that, we're not taking people who have dementia, so maybe people with dementia have a high risk of developing pneumonia. So obviously we don't want to confound that, our analysis. So we made sure all of these people had 4 medical encounters before the pneumonia encounter, and made sure that in neither of these encounters a diagnosis of dementia was given. So there was a pretty thorough screening for this group in terms to exclude a medical diagnosis of dementia. And then we didn't take admission within the next 30 days because that has been the definition of the acute phase. And I know that there's some differences in where that number should fall. I think some people start defining convalescent phase after 21 days of the diagnosis of initial infection. The Centers for Disease Control and the European Centers for Disease Control both actually use a 4-week period, and several studies have used a 4-week period. But I think for some immunological study, they may actually be using all the way to 8 weeks to define convalescence. But for us, 30 days seems to be the number that most people agree on. So we use 30 days. And these patients had to have 2 or more admissions after 30 days so that we can actually screen for who developed new onset dementia. And we want to make sure that, there is enough medical information captured in the post-recovery period so that we are not missing out on any diagnosis of dementia. And we used the ICD-10 codes to define, as a primary diagnosis code to diagnose dementia. And the ICD-10 code seems to be pretty sensitive to pick up the diagnosis of dementia. I think there's several validation studies that have been performed validating the use of ICD-10 codes for ascertainment of dementia. So if you look at it, so 3% of the patients who actually had SARS-CoV-2 infection developed dementia. 2.5% of the patients who had pneumonia without SARS-CoV infection also developed dementia. So obviously there's 2 things that you can assess based on these numbers. One is that patients who have pneumonia still have a risk of having dementia in the post-recovery period. However, the risk seems to be higher and significantly higher in patients who actually have SARS-CoV-2 infection. So there is something unique about pneumonia with SARS-CoV-2 infection that is not seen in pneumonias not associated with SARS-CoV-2 infection. Now, it's still an absolute difference of 0.5%. So, one may argue that, yes, it makes statistical significance, but it really is significant from a societal perspective. So if you look at how many people in United States get pneumonia every year, so 1 million people, so if let's assume somewhere around 2.5% actually have dementia. So that's around 25,000 people every year getting dementia. And now you have 5 million people additionally getting SARS-CoV-2 related pneumonia. So you have on top of it another 150,000 people getting new dementia. So this is a significant jump in new dementia in United States, and I'm sure these numbers reflect globally as well. So even though the 0.5% number can translate substantially into a much larger number of patients when you look at it from a national perspective of those getting new onset dementia. And it actually differs that the risk of having dementia or new onset dementia is very age related. So if you look at pneumonia patients, the biggest difference is in pneumonia patients who actually are 70 years or greater in age. So you can see a very dramatic difference in the rate of new onset dementia in the elderly population. 6.4% of the patients with SARS-CoV-2 infection develop new onset dementia compared to 5% in the non-SARS-CoV-2 related pneumonia. So somehow the increased tendency of SARS-CoV-2 infection to cause dementia is age dependent. So really the SARS-CoV-2 infection takes a greater brunt in the elderly population. So obviously, there can be differences in other risk factors for dementia. So obviously that's the value of doing multivariate analysis, trying to adjust for the other risk factors. So making sure it's not just because patients with SARS-CoV-2 infection of other risk factors of dementia, and essentially you're just saying a manifestation of that increased burden from other risk factors and has nothing to do with SARS-CoV-2 infection. So if you do the multivariate analysis in this study, and if you look at the SARS-CoV-2 infection after adjusting for everything that we could, the odds ratio is 1.3 with a confidence interval between 1.1 to 1.5. So it is actually significant and is significantly different despite all the other adjustments that one could make. And essentially, you do additional adjustments in model B or 2, you still see the risk persist independently. The odds ratio do not change even after adjust for other variables in the analysis. So the model 1 is actually adjusting for the baseline demographic characteristics, cardiovascular risk factors, and other known dementia risk factors. In model 2, we are also adjusting for the severity of illness or the severity of pneumonia using markers as septic shock, intubation, mechanical ventilation, or any stroke during the reference encounter. And despite all these adjustments, SARS-CoV-2 infection is an independent predictor of dementia after in the recovery period or the convalescent period after the initial infection. And the odds of new onset dementia were 30% higher with SARS-CoV-2 infection compared to other pneumonias. So based on this information, there is some statements here, and it would be interesting to know what people feel, how convincing they feel the data is, and how it has actually changed or perhaps consolidated their perspective. So we think that patient survivors of bacterial pneumonia have a higher risk of pneumonia, dementia as compared to those without pneumonia. Do we think the survivors of SARS-CoV-2 related pneumonia have a higher risk of dementia than survivors of other pneumonia? And then essentially, do they actually have a higher risk of dementia, and that's just because they have a higher risk of stroke?
Give it a few more seconds.
Yeah, no, I'm actually very curious to see the poll result because it's not just my information. People are actually putting their own research and thoughts into it. So it kind of becomes more broadly reflective of where we are.
And we'll remind everyone that this question is there could be multiple true answers, correct? So you can select more
Yes,
than one,
yeah, you
right?
can choose.
Okay. They can select more than one.
Unlike most times in life, you have multiple choices here.
Okay, we'll be wrapping up the poll now. Let's processing the results.
Okay. So I think most people actually seem to agree with what I was saying. So I'm happy about that. Thank you. Thank you for that vote of confidence. And I think that I just want to say one thing about the risk of stroke in SARS-CoV-2 infection and whether that actually contributes to the risk of actually dementia. I think that what has happened in the last, few months is that several studies have shown that the risk of a acute ischemic stroke or any kind of stroke during the SARS-CoV-2 infection is perhaps not higher than any other infection. So I think that this whole concept of inflammatory thrombosis, because that is the concept that you have inflammation because of the infection, and inflammation actually changes the whole system to a prothrombotic state, perhaps does not have a lot of implication beyond just any infection for the development of acute ischemic stroke. So I think we actually had to step back from that initial concept that yes, there is a much higher risk of having acute ischemic stroke during SARS-CoV infection, to the point that people were actually advocating using anticoagulation during infections and definitely antiplatelet agents. And I think we've all taken a step back, and perhaps we don't need to use all these medication unless some new evidence actually comes forward. So now the question becomes is why? So yes, perhaps there is a greater risk of cognitive deficits all the way up to dementia after the SARS-CoV-2 infection, and the question is why? So obviously, initially people thought that yes, there are hypoxemia, there is cerebral ischemia because of hypoxemia, because of the pneumonia, there could be hypotension because of the septic shock, and all of that is actually taking a brunt on the brain and causing neuronal injury. And the dementia actually is a consequence of that neuronal injury that was incurred in the acute phase. And that's not true to just SARS-CoV-2 infection. That can happen with any pneumonia or any illness. And then there was this concern about direct infection. So the SARS-CoV-2 infection actually directly, or the virus directly entering the brain, causing meningitis or encephalitis, and that causing neuronal injury. And then obviously there was this inflammatory response. So I think that is pretty clear that SARS-CoV-2 infection, that like any viral illness, perhaps a little bit more than other viral illnesses, invokes a strong inflammatory response, which means expression of several inflammatory mediators, including interleukins. And these interleukins are the ones that are actually causing a immune activation within the brain, and that immune activation is causing neuronal injury. Now the question is, obviously a lot of these mediators can't cross the blood-brain barrier, so why are they actually activating the brain? And one potential is that there are actually gaps in the blood-brain barrier in what we call as the circumvent organs, and perhaps they're entering through those gaps. Second is that they're actually disrupting the blood-brain barrier and allowing the breakage of blood-brain barrier and subsequently moving into the extracellular spaces in the brain. And the third is actually just activating the capillary endothelium of the blood-brain barrier and initiating release of secondary mediators like prostacyclin or prostaglandin E2, and that is actually causing immune activation in the brain, causing neural injury. And I think there's actually an interesting hypothesis that perhaps there is actually increase in vagal nerve activity that you can see through any inflammation in the chest. And that increase in vagal nerve activity is somehow modulating the inflammatory response intracranial or in the extracellular spaces of the brain. So there is several pathways where you can see neuronal injury that may form the basis of cognitive deficits and dementia. And perhaps it's a combination. It may not be just one pathway. It may be more than one pathway that's involved. But I think one of these pathways actually has lost some credence, and that's actually direct inflammation or direct infection of the brain. I think more and more data is coming in that virus does not enter the brain. And direct meningitis and encephalitis, like we see with other viral infection, is perhaps not seen with the SARS-CoV-2 virus. But perhaps there is actually a immune activated demyelination and encephalitis. So more in the path, more on lines of what we call as post-viral encephalitis and demyelinating encephalitis, like a term like ADEM that has been seen with other viral illnesses. So I think that that is probably gaining more support as we move forward as another way where you're seeing neuronal injury even in the post-acute period after SARS-CoV-2 infection. Now, obviously, people have asked this question that do you still have an increased risk of cardiovascular events after you've recovered from the SARS-CoV-2 infection? Because that is a lot of implication. Should these people be on antiplatelet agents after they've recovered? Because if they have a higher risk of having cardiovascular events, then they should be on something to prevent a new cardiovascular event in the convalescent period. So we did another analysis of the same data. So this time we used patients who actually had SARS-CoV-2 infection-related pneumonia, so 10,691 patients, matched with another 10,691 patients without SARS-CoV-2 infection, but obviously everybody had pneumonia. And then we actually followed these patients after the first 30 days to look for any cardiovascular event, which could be ischemic stroke, it could be myocardial infarction, it could be hemorrhagic stroke, to see if there was an increased risk of cardiovascular disease in the convalescent period. And essentially, if you follow these patients after the first 30 days, there doesn't seem to be any difference in the risk of new cardiovascular events among survivors of pneumonia with the SARS-CoV-2 infection. Now, obviously, our controls are coming from a group of patients with pneumonia. So you have to be careful that patients with pneumonia have a higher risk of having cardiovascular events in the post-infectious period. So we are not really comparing them to people that are in normal population, healthy controls. So perhaps if you had used that as a control, maybe there was an increased risk of cardiovascular events among the survivors of the SARS-CoV-2 infection. But from the practical standpoint, for every SARS-CoV-2 infection survivor, which again is more than 500 million people worldwide, the National Institutes of Health, the COVID-19 treatment guidelines recommend anticoagulation and antiplatelet therapy should not be initiated for prevention of venous thromboembolism or arterial thrombosis in non-hospitalized patients with SARS-CoV-2 infection, unless the patient has other indications, so you may have other cardiovascular risk factors, or is participating in a clinical trial. And then Dr. Lin Chens and his group did an extensive review of all the pathophysiology of the SARS-CoV-2 infection-related coagulopathy, and also looked at data from randomized clinical trials, and then essentially concluded that routine antithrombotic treatment is not recommended in patients with SARS-CoV infection after discharge. So I think there is pretty consensus here that once we're looking at patients with SARS-CoV-2 infection survivors, we don't need to use antithrombotic agents once they've left the hospital. So what are the implications with what we have found so far? I think that occurrence of new dementia may increase the burden of disability among survivors of SARS-CoV-2 infection. And I think that even all the way to the US president recognizing that the infection is not over, or it's not over for the survivors of the infection once they've recovered from the acute infection. So we actually have to look at it as a disabling disease, unlike other viral illnesses where you just survive. And if you've survived the acute period, you should be able to go back and integrate into normal life. I think that many organizations, including the National Institutes of Health, emphasize on the long COVID, that it is a debilitating disease. And essentially, it's insane. 80% of the survivors are saying they're having difficulty in their going back to work. 36% are saying they're having negative financial consequences. So obviously, it's not over once you have survived the infection or the SARS-CoV-2 infection. And Social Security, which is actually responsible in the United States for assigning disability, are already starting to issue guidance how to deal with the post-COVID condition, how to integrate it into the disability assignment for all the people who actually are coming in seeking their opinion. Now, it actually takes us to another discussion, the long COVID or the post-COVID condition. So essentially, data is coming from survivors that these patients still have problems. And it's a spectrum of problems. So it's not just one problem they have. There's a whole spectrum of problem they're having once they made it past the 4 weeks of the acute infection or have entered the convalescent or the recovery period. They can have respiratory symptoms, dyspnea, they can have fatigue, they can have post-exertional malaise, poor endurance, obviously this entity of brain fog, which may actually be a variant or a manifestation of cognitive impairment. They can still continue to have respiratory problems like cough and chest pain. Interestingly, headaches. You can always have cardiovascular events, arthralgias, myalgias, and then you have a whole set of other problems, which can be abdominal pain, diarrhea, you have insomnia, you have fever, you have actually impaired mobility and daily functions, mood changes, you have anosmia, you have menstrual cycle changes. I think that there's actually new data coming in. You are more likely to develop diabetes mellitus once you have recovered. You may actually have alopecia, which is actually very interesting. So there's some new data coming there as well. So this long COVID is a very interesting disease, and the Centers for Disease Control and Prevention have issued an interim guidance for the post-COVID conditions. They are actually using the umbrella term post-COVID conditions, and they recognize it's a wide range of signs and symptoms. Only thing that common is they happen 4 weeks or more after the acute infection. And the standard definition still lack. What is the standard definition, even if we put all the signs and symptoms in the post-COVID condition? And the standardized definitions are still being developed. And I think our talk today emphasized on one aspect of the post-COVID condition, which is the cognitive impairment, which obviously still integrates with some of the other manifestations as well. But I think that just is one spectrum of the post-COVID or the long COVID conditions. So I think in terms of concluding, where do we go from here? I think obviously there seems to be need for screening of cognitive deficits among survivors of the SARS-CoV-2 infection. Well, we have several screening tests. We have the St. Louis University mental status examination. We obviously have the most commonly used, the Montreal Cognitive Assessment, and perhaps the older variant, the mini mental status examination. Obviously, none of them was developed for screening for cognitive deficits in patients who have SARS-CoV-2 infection. But nonetheless, this is what we have at this point. But still the question that remains, who? Who should be screened? Should everybody be screened? Are there certain group of people that should be screened? People who are actually older should be screened. People who had certain events during the acute hospitalization should be screened. When to screen them? So is screening at 1 month the recommended way? Or some of them having transient deficit that may actually resolve, and perhaps screening at 3 or 6 months makes more sense? How to screen? Which batteries to be used? Shall we use the normal screening test? Should we be actually using more detailed neuropsychological evaluation? And once we actually determine, then what? Are there certain treatment paradigms, certain support services that need to be integrated? Essentially, do we need to allocate a certain number of resources that should automatically jump in when somebody is actually diagnosed with cognitive deficits after the SARS-CoV-2 infection? And I think from a societal perspective, the bigger question of what do we say as disability? And Social Security needs to actually decide whether new onset dementia after SARS-CoV infection meets the definition of medically determined impairment, or MDI. Because essentially that's what Social Security determines, that if you have an MDI, you're not going to be able to work for 12 months, and thus you are eligible for the support services that come with Social Security. So I'm actually going to conclude here and actually open the forum for questions. I hope that I was able to give information that actually pointed not just to dementia, but actually how it integrates into the broader picture. Thank you.
Thank you very much. Very interesting, and we did get some questions from the audience. I'll actually start with a question relating to the last slide, just because you had it was sort of next steps, and there are sort of I guess you're general, and maybe there were kind of questions for the audience or for the reader. But I guess concretely or practically, what do you think? What do you recommend should be done? I know that's a big question, so maybe at least relating to cognitive screening, what do you think should be done in this post-COVID world?
I think that till more data is available, we have to figure out a way to screen everyone. Now,
Mm.
the problem obviously is easier said than done, man. And do we have the resources to actually screen everyone? And I think that, so if we take the task and say, yes, everybody should be screened, but how to make it practical? And then, whether there are self-administered tests, whether we actually have to use web-based resources to make it available to the broader population who, survivors, the broader population of survivors. I think that's where we have to focus our efforts. And I think just using dedicated clinics perhaps is not going to be practical. So I think we have to make it somewhat more accessible to the survivors. And I think whether web-based resources is the answer or not, I think it's probably something we have to consider.
Great, thank you. Another question, or I saw a few times this question came up, if there was any relation to Alzheimer's disease. So in the dementia group that you looked at, was there any biomarkers, amyloid, tau present, anything that would suggest some sort of relationship with Alzheimer's?
So when we use the term dementia, I think that there is an increased risk of dementia, and actually we did not do this analysis yet, but I think that there is data from other dementia that are related to pneumonia that it's actually not just one particular form of dementia that has a higher chance of developing. People are more likely to develop Alzheimer's disease. People are more likely to develop vascular dementia, and people are more likely to develop non-specific dementia. So somehow it's just triggering a pathway that actually doesn't go into a single form of, I guess, cognitive impairment or a single form of neuronal injury. It actually triggers a broader set of neuronal injury pathways.
Okay, interesting. So I guess that leads to my other question. I guess from your professional opinion, at least in terms of from a neurological perspective, do you predict there'll be maybe some surprises down the line? I mean, we're seeing long COVID, we're seeing this relationship with dementia. Do you think there's going to be some other things that are going to come out in terms of neurological complications further down the line that are COVID related?
I think that, this long COVID is just beginning to be defined. I
Hmm.
think that some of the symptoms that we talk about may just be non-specific and may just be related to any illness. So they will probably be removed from that long COVID description. But there's going to be new entities that are going to find their way into the long COVID. I think that there is some new data, and actually we are looking at it as well. So whether that actually pans out or not is the risk of acute demyelinating encephalomyelitis in the post-infectious period. Obviously, there are reports there that that happens after the SARS-CoV-2 infection. Is that risk higher than any viral infection? We do not know. We are in the process of doing a study trying to look at that. So whether that actually assumes a greater role in the post-COVID condition, obviously, is a question. And then secondly, if so, it actually opens the role of immunomodulation in the post-infectious period. So there may be something that can be done in the post-infectious period to actually reduce the burden of the long COVID.
Okay, so at least some encouraging words. I guess maybe one last question. The um, oh, my apologies. So the we saw some low scores, let's say on MMSE or on the MoCA, that were indicative of cognitive impairment. Did you notice in your group specific cognitive domains that were being impacted, or was it more of just a generalized low score?
That's a very good question, and because that has actually implication of what to screen for.
Mhm.
So, and I think that so far the data has been somewhat diverse. That several domains are being affected. So I think that we haven't been able to identify like one or two domains that actually are characteristic of the cognitive impairment after the SARS-CoV-2 infection. So we haven't been able to narrow it, and at least the initial data doesn't support that it may be possible to narrow it to like one or two domains. It may be broader than that.
Okay, excellent. And I do have one last question, just because someone asked it once again, and I wanted to ask this question. We did notice that there was a gender cohorts had a different outcome. Was there any differences in by that was age sorry age cohorts? Was there any difference in genders?
We did not
Great.
find any, but
Okay.
we did not find any. But that is a very interesting question, and it actually is because the women may actually be on the older cohort, so it's going to integrate with the age question as well.
Hmm.
But yeah, we did not find any in our initial analysis. It's quite possible that the number of patients or survivors grow larger, so more detailed gender-based analysis could be done.
Okay, wonderful. So great. So I guess there's a lot of interesting next steps, and I know that you're involved in a lot of research even beyond this. So I encourage everyone in attendance to follow Dr. Qureshi's current research. It's very exciting. It's all related to cognition. So many thanks for your time today, and we'll hopefully be in touch. And for all the audience, we'll share with you the slides, the recording, and the certificate of attendance shortly. You'll be notified by email or on our website. So thank you very much. Cheers. Have a great rest of your day. See you.
Thank you so much for having me, and thank you so much for everybody who participated. It's just an absolute pleasure to be in such a global forum. Thank you very much.
Over 1,000 people. See you. Bye bye.